Can you hear me okay?
Before we start, I just ask people if they haven't still got their mobile phones on to switch them on, please. Thank you very much. Sorry.
Just to give a little bit more of an introduction, I am a consultant psychiatrist. I work at the North East London Mental Health Trust, so quite near here. And I also have an academic part to my job at University College London. And I've had a long-standing interest in psychiatric drugs. It feels like a decade to me, because it sounds like to you. Which is what I'm here to talk about. I'm also one of the chair people of the Critical Psychiatry Network. Some people may have heard of that. We're a band of psychiatrists who are sceptical of mainstream use of psychiatry and campaigning on various issues. So, I haven't got terribly long, and what I'm going to try and do is summarise to you the main ideas in what I've been writing about. They're summarised in my book, The Myth of the Chemical Cure, and also in various other papers and pamphlets I've done. And I wanted to try and do that quite briefly and then take some questions, have some time for discussion, because I find that very useful. So, what I've been trying to say for many years now, really, is that the way that drugs are presented by psychiatrists in psychiatry is it's a misrepresentation, and they are drugs are given more credit than they really deserve by the suggestion that they have specific or curative effects. And what I'm suggesting is that we need to look at drugs in a different way. We need to understand them not as ways of reversing underlying diseases, but as drugs that alter the body and the mind, as drugs do. And we need to understand what these effects are in order to see when they might sometimes be useful, but also in order to understand how they can be harmful. So what I'm trying to do in order to get rid of this area is I've formulated two different, what I call models of drug action. So these are two different ways of understanding the way that psychiatric drugs might be working. And the conventional way of understanding psychiatric drugs is what I call the disease-centered model. And I do apologise for what's written here. I think someone called me on a day when I didn't have time to write anything, so it doesn't really seem to make very much sense to me, so I'll try and explain it now. Anyway. So, the disease-centered model, the disease-specific model, is the mainstream, the general mainstream view in psychiatry of what psychiatric drugs do. And this is the idea that they are somehow working on an underlying disease, or some sort of underlying abnormality, and that they're rectifying that in some way. So this is often put across as the idea that they're rectifying underlying chemical imbalance, for example. But it's an idea that's borrowed from general medicine, and the paradigm example that's often used is the idea of giving insulin to people with diabetes. In this case, the insulin is not curing the cause of the diabetes, because that's failure of the pancreas, but it's helping to move the body to a more normal state. So it's working on the disease process, the things that have gone wrong. But even things like painkillers work in this way, because again, they're not addressing the cause of the disease, obviously, but they are working on the processes that produce the pain. So this view can see drugs either as acting on symptoms or on the causes of diseases. It doesn't have to always be the cause of the disease. But the important thing is that the drug's acting on the physical processes to move them to a more normal state. And the contrasting view that I set up is what's called the drug-centered model of psychiatric, of understanding what psychiatric drugs do. And this, as I said, is looking at psychiatric drugs as drugs, and saying that what they're doing is not normalising an underlying problem, an underlying disease. In fact, they're creating an abnormal state they're creating a drug-induced state, and drugs affect both physical and mental processes. And it's these abnormal drug-induced effects that actually are the desired effects when you're giving psychiatric drugs. And sometimes they can be useful, sometimes they're useful for the people who are in distress, sometimes they're useful for the people around them. So an example I often give to illustrate this view is the idea that alcohol can be useful for people with social anxiety disorder. And this was a fairly mainstream thing that we used to learn about in medical school. So it's not that the alcohol is rectifying an underlying chemical imbalance, or that people have an alcohol deficiency, obviously. The idea is that the state of intoxication that alcohol produces involves a certain amount of social disinhibition. That's the sort of drug that alcohol is, and that's it produces this characteristic state which is socially disinhibiting. And that state, that drug-induced effect may be useful in people with social anxiety. So this second way, what I call the drug-centered way of understanding psychiatric drugs, is seeing psychiatric drugs, understanding psychiatric drugs as psychoactive substances which alter the way that we think and feel. And they also have physical effects. Most drugs that alter the psyche also alter the body in some way. And other properties of psychoactive drugs are that often if you keep taking them, often their effects reduce. And the body produces adaptations to try and counteract the effects of these drugs, which is why you often get withdrawal symptoms if you stop them suddenly. So, what I'm suggesting is that psychiatry is presenting psychiatric drugs as being specific, disease-specific treatments, when actually they're acting not in a disease-specific way, but just by inducing altered states, putting people into altered frames of mind. And those altered states can suppress the manifestations of a mental health problem sometimes. And just briefly to give you the history of these ideas, in the early 20th century, there was very little concern about treatment. It wasn't really generally thought that mental health problems responded to treatment much at all. So textbooks of psychiatry at that time really gloss over treatment entirely. And they just talk about people having lots of fresh air and how that would be good for them. In the middle part of the 20th century, psychiatry gets quite excited about treatment, and this is around the time that various physical treatment procedures get introduced, like insulin chemotherapy and ECT. And gradually people come to see these treatment procedures as having some sort of disease-specific effect. They don't know how they're working, but they believe that somehow they're acting on the physical basis of the condition, the presumed physical basis of the condition. Now, there were lots of drugs being used in psychiatry at this time, lots of sedative drugs like barbiturates and paraldemide, bromides. But they're not regarded as being specific. They're regarded as being simple sedatives, a form of chemical restraint. And no one talks much about them, and it's almost as if psychiatric mental health professionals are really embarrassed about them, about having to use them, but they are used a lot. But when the new generation of drugs come along in the 1950s, the drugs that we're familiar with, what have come to be known as antipsychotics and antidepressants, they come to be seen as having a specific effect, and it's almost as if they take over the role of things like ECT and insulin chemotherapy, these physical treatment procedures that were very cumbersome, very dramatic, and sometimes